In this year's lecture series, I'm going to be talking about public health. And today, I'm going to talk about one of the major issues in public health, which is the role of the state in helping to prevent disease. If we go back to when this college was founded in 1597, the average person in the UK lived around 40 years, but many people died in childhood. And that continued all the way through to around the 1850s. And at that stage, we started to see a gradual and then steady improvement in health through to a point now where the majority of people live to 80 years or more. This has been something which has been seen across much of the developed world and increasingly, fortunately, in lower and middle-income countries as well. And what this talk is going to explore is what is the role of the state in this improvement, and what should it be doing, and what should it not be doing, and where are the areas where there is uncertainty. Now, if we look at this improvement in mortality over the last 150 years, the initial improvements were in child health. And in this graph, what you can see is various decades, starting from 1850s, all the way through to the last decade. And initially, the big improvements were in child health. Many people could still die all the way through their adult lives. But over the last 50 and 100 years, we have seen significant improvements in health all the way through adulthood as well. So the great majority of people live through to a good old age by historical standards. And you can see this has been particularly true for certain classes of disease. On the dotted line here, this is UK mortality rates from infectious disease, heart disease and stroke and cancer. In the dotted line, infectious diseases over the last 100 years have really disappeared as one of the major causes of mortality in younger people, although it is still a significant issue for all of us in older age. Cardiovascular diseases, strokes and heart disease, reached their peak in round about the 1950s and then have steadily improved. And for both of these major improvements in health, state interventions to help prevent disease have played a very major role, not the only role by any means. Medicine and the actions of individuals, and above all, people becoming wealthier, and through that, having better diets, better housing, better prospects, have all contributed very substantially. But the state preventing disease has played a very major part in this. And in the dashed line are mortality rates from cancer, where again, state prevention can help very substantially. Most people would agree with the old saying that prevention is better than cure. And public health, what this series is about and what this talk is about, is aiming to prevent disease and therefore to extend healthy life, reduce ill health, reduce indignity, and reduce disability by prevention. And I've illustrated this with our own head of state, the Queen, in her 90s, and another great servant of the state and the rest of his fellow citizens, Colonel Sir Tom Moore, now 100 years old. The aim that we should have people living full and happy and fulfilled lives is what underlies the principles of trying to improve public health. Now, within that, I think everyone listening to this would accept that individuals have the principal responsibility and role in helping to protect their own health. Medical professionals, like myself, also have a significant role in helping to do this through prevention and also, very importantly, through treatment. But the state also has a responsibility and a role which is defined by what citizens want it to do. Now, much of public health, much of prevention does not actually need the state, and that may vary by different nation. But some of it definitely does, and that will be the majority of what I talk about today. The The state has the capacity to prevent ill health and deaths in many citizens. The real question is, when should it? Now, how you would answer this depends very heavily on your discipline, your nation, and your time in history. I'm a medical practitioner, so I've illustrated this with doctors and one extraordinary person, the person who founded nursing, Florence Nightingale. Several of these, the people illustrated here, were significant philosophers or worked in the courts. The court as in the court of the monarch of the time. Some of them were very important in our understanding of what states should do. For example, John Locke was a doctor as well as a philosopher. Some doctors have been involved as heads of state, like Dr. Banda here, and some have been involved in multilateral areas. All of these people from different continents, different ages, different traditions, would answer this question, what is the role of the state, slightly differently. And political tradition around the world is also important. So unlike many of the other talks I've given in previous series about infections, about cancer, cardiovascular disease, dementia, and so on, which are really fundamentally about where is the science at this point in time, what is our current state of knowledge, this is something which has varied through time, both because of the science, what is possible, but also because of contemporary beliefs. This is therefore a personal view from a medical practitioner working in state medicine and as a doctor on the wards in 2020. Previous medical practitioners and subsequent ones would probably give slightly different answers because people's belief in what the state should do does inevitably change. Now, running through this, it's important to understand one broad set of principles about how to think about prevention in healthcare, and this underlies a lot of public health. Conventionally, public health prevention can be divided into three different types. Primary prevention, and this is when you take the disease-free population, people going about their ordinary lives at all stages of their life, and things are done which are there to try and make sure they do not get infections, do not get other diseases from their current state of being healthy. So to prolong as long as possible their completely healthy state. Then you have secondary prevention, and this is something which is about largely trying to identify early disease or identify people who've got particularly high risks of disease. For example, they might have high cholesterol and high blood pressure as risks for cardiovascular disease, and then intervene to delay progression. And finally, you have tertiary prevention when someone's got a significant disease. For example, they might have had a small stroke, and you want to make sure they don't go on to have a larger and more disabling one. When we think of the separation of the responsibilities between state medicine, what the state does, and I've capitalized it throughout just to avoid any ambiguity, and what individual medical practitioners do to help support citizens and their families to maintain good health in terms of prevention, it does tend to vary slightly between this primary, secondary, and tertiary prevention. The reality is that most people only go to a doctor when they or their family are unwell. And primary care physicians in the UK, GPs, and specialists in hospitals generally have the central role in secondary and tertiary prevention, in finding people who've got early disease or risk factors for disease, and then trying to intervene early to prevent that progressing. And this, importantly, is based on individual consent, because you can talk as a doctor, as a nurse, as another medical practitioner to the individual person and their family, and you can say, these are the risks, these are the benefits, this is what we think is a good idea, and then discuss the pros and cons. Primary prevention, which happens within the overall society, for those not yet unwell, it's very difficult to have the same kind of discussion. And this kind of prevention, which happens for the whole population, generally falls to the state. It may have medical practitioners within it, but this generally falls to the state, along with what's called health protection, which is largely to do with preventing people getting significant infectious diseases, particularly in epidemics. Now, in democracies, the role of the state must depend on what citizens want the state to do. And this is expressed through their elected government. And it's the job of people like myself, directors of public health in local authorities, in local government, and others, to lay out the evidence and say what can be done by the state to improve health, and the risks either way, of doing things and not doing things. It is absolutely the role of elected politicians, whether they're the elected government of the day, whether it's parliament, or whether it's local government, to decide what should be done by the state. And this becomes more important the more interventionist the state has to be to try and help protect people's health. So there is in public health the concept of the ladder of intervention. You start off with things which are relatively uncontentious and do not require significant state powers, but then you move up it if that is what the population, expressed through the democratic process, think is the right thing to do. At the bottom of this are things like supporting science to test out possibilities, informing the public that risks are there, and engaging positively with industry to say, look, let's have a voluntary discussion, for example, about how you could reduce salt, which is a known risk factor for high blood pressure and therefore stroke. And that's been very successful in many cases. This is not using state power, this is just using the ability to actually engage in conversations. Slightly more use of state resources are mass voluntary programs. These are things where people can choose to be part of them or not, but they are provided by the state. Things like vaccination or screening if people wish to have them, and generally they're only recommended if there's a high evidence base that they should be. Nudge taxes, quite small taxes or interventions that are designed to push people slightly one way rather than another. And then you go to more extensive use of the ability of the state to intervene. And this might involve regulation, more heavy taxation, outright banning of products that are very dangerous, and at the extreme end, making individual citizens subject to the civil or criminal law. And the more you go up this ladder of intervention, the more central the role of elected politicians is in deciding what is the appropriate way that the state should respond. And it is very important for people involved in public health, particularly when they're in the state system, so in local government or in general government, to be very respectful of the fact that the tradition that the state should interfere as little as possible is a long and honourable one in this country and every other country, on both the left and the right in politics, in the law, which I've illustrated here by one of our distinguished judges, Lord Sumption, newspaper commentators with, I have to say, varying degrees of consistency, but all of them would agree that there are some things that only the state can do when it comes to preventing disease. Now, this is not set for all time. The set point of public and parliamentary opinion about what is the appropriate things for the state to do to protect the health of citizens varies over time. I'm going to take a relatively extreme example just to illustrate this. It was actually quite controversial in Parliament when it was first proposed that the state should prevent children under the age of 10 being sent up chimneys to help clean them. It was widely recognised it was a horrible life for the children, many died. It was accepted that it caused lifelong health damage to the children, who usually had a very short life anyway. Most of them came from very poor families. But it was thought at that stage, by some in Parliament, an unnecessary imposition on trade. Campaigning to stop this began in the 1760s, But it took over 100 years before an effective act was brought in, because there was not absolute unanimity, and not even a majority, actually, for some time, for an effective intervention to prevent this. Now, we look back on this and we say this is quite extraordinary, but that is because views about what is reasonable change over time. So I'm just using this to show that this is not necessarily set at any point in time. And this can go in both directions. As I'll come on to, with some issues, the state now interferes significantly less than it did historically. So it can go in both directions. The central point I want to make, though, for the rest of this talk, is that for most risks to health, there are three possibilities at a particular point in time. The first is that the public overwhelmingly expects the state to act and would be very critical if it did not. A government that went into a general election on a manifesto of saying we're not going to do this would be doing themselves significant harm with the citizens who would say that's extraordinary. At the other side, there are very many things where the public overwhelmingly expects the state not to interfere and would be very critical if they did. And I've illustrated this. If, for example, a government proposed that we should ban rock climbing for children or ban licorice all sorts because they were bad for children's health, this would be considered undoubtedly a significant overreach in state powers at this point in time. And I think at any point in time, it is actually fairly obvious to most citizens, most people who think about this, most people in public health, and above all, most ministers and politicians, where this lies, what the citizens want the state to do and what they do not want the state to do. And then there are some areas where the public is split about how far they want the state to intervene, and this is where political tradition about the role of the state comes most into play. But as I'll go on to, I think that a very large proportion of the things where citizens want the state to act, it is a very clear decision, and it is for good logical reasons. And these, broadly, are the three areas where the public expects the state to act, and usually has for generations, centuries, or in some cases, millennia. The first group of things is where the risk to health is shared across society. So if your risk increases, my risk increases, and vice versa. And examples of this are epidemics, where if I catch an infection, it makes it much more likely than the next person I meet will catch an infection, so protecting me protects them, and vice versa. Infectious diseases more widely, including vaccination, clean water, safe food, and a variety of other things we'll go through. Pollution, both air and water, because it is very difficult to reduce pollution for me, but not for my neighbour, so this has to be done at scale. Then there's a group of things where a major power imbalance may kill people or cause significant harm. And examples of this are industrial injury and occupational disease, where people, solely because they go to work, are harmed in terms of their health. Industries based on addiction, like smoking in particular, some other drugs, and industries which are potentially dangerous, though important for society, such as motor vehicles. And finally, there is a long-standing tradition of protecting the most vulnerable, and in particular children and people who are pregnant with babies. Now, I'm now going to go through those in turn, but in each of these, the reason that citizens want the state to act, I think, is logical and stems from the fact it is very difficult to improve my health, my family's health, without improving also the health of my neighbours. The first of these is states intervening to reduce the impact of epidemics, and there is clear evidence of this going back many, many centuries, and indeed, in some cases, millennia, following contemporary beliefs. Governments acted to try to reduce the risk of epidemics in every society for which we have records going back very, very far back in history. And much of what we see in current views about how we manage epidemics actually have very old antecedents. For example, quarantine laws for people coming back from a country which might have been infected, 14 days was the original for much of the legislation. For example, in Venice, brought in the plague pandemic, so it could go up as long as 40 days, goes back to the Middle Ages. The state often acted forcefully to detain sick people in an epidemic and to isolate them, to prevent onward transmission. And there have been, for many centuries, during epidemics, bans on what are seen as high-risk or close contact occupations, for example, barbers, also medical practitioners, and a variety that we probably wouldn't want to talk about in a family setting. John Snow's demonstration that contaminated water caused cholera in 1854 was a turning point in turning this from it makes sense to the general population into basing it on what we would now see as scientific evidence. This was really the beginning of epidemics being seen by epidemiology, a branch of science that looks at large-scale infections and other non-communicable diseases. Now, the history of this is probably just worth briefly repeating. 7 massive pandemics of cholera happened. The first starting in 1817, 7th is still ongoing. It's killed tens of millions of people. It's a huge issue. It was extraordinarily frightening to be living through. In the 1854 London epidemic in this city, mortality rates of up to 12% in a neighbourhood were seen. And Snow famously mapped cases onto certain water companies. What he found is some water companies had much higher rates of cholera than others, and famously also onto the Broad Street pump in Soho, which he rather theatrically removed the handle from. This really started off a tradition of scientific approaches to trying to reduce the impact of epidemics, and combating cholera, typhoid, and other epidemic diseases was considered the most important role of state medicine for really quite a long period of time. This is where a lot of state medicine started off. And consistently, populations around the world, going back right into history, but up to the current time, where we're going, for example, through the most major pandemic for many decades, the current COVID-19 pandemic, have consistently wanted, indeed demanded, that their state acts to help protect them from the pandemic. And if you think about support for this in the UK now, the lockdown measures that happened in the UK earlier this year, which were some of the most significant curbs to freedoms the state has actually introduced for many decades, were supported overwhelmingly in all the polling that was conducted, over 90% support for these really quite strong measures by the state. And indeed, in late 2020, quite a lot later, the public still remain substantially, by a substantial majority, in favour of ongoing measures. All ages, all social groups, all political persuasions. This is across the board. So this is an area where public support in terms of the state intervening to help reduce epidemics, I think is pretty clear why people do it. It's because my risk is your risk, but it is also clear this commands strong citizen support. And overwhelmingly, people intend to follow advice to protect themselves, their families, but also, importantly, other people. But they also want other people to do so as well, or their own sacrifices and decisions seem in vain. And since in all epidemics and many other infectious diseases, if I increase my risk, I increase it for everyone around me. And if most people want to reduce the risk to themselves, their family, and all vulnerable members of society, which overwhelmingly people do, many people take very altruistic views on this, almost everyone does, in fact, they don't want others to increase the risk to the entire community by, as they would perceive it, freeloading, although this perception is often actually quite unfair or exaggerated. The great majority of people in the current epidemic, for example, absolutely intend to follow all the rules. They are worried that other people will not, but in fact, the great majority of other people also want to and do follow the rules. But only the state can help ensure that we all reduce the risk of this and other epidemics. This is a general point, not about COVID. The state has the authority and the resources to act fast in an epidemic and therefore to limit the damage. Whether imposing lockdowns, travel restrictions, switching research priorities, expanding healthcare, underwriting furlough schemes, these are just recent examples. It is not really obvious what the alternative to the state doing it if an epidemic or pandemic hits. And interestingly, this has actually possibly and maybe temporarily changed the views of citizens about where they feel the balance of responsibility between the state, health practitioners, local government, which is another part of the state, and the individual sit. So here are two polls done by Ipsos Mori, one in 2018, one in 2020, and both of them show that overwhelmingly the individuals feel that the predominant responsibility for maintaining health is the individual, certainly the individual adult. National government and local government, however, have seen a significant increase in the expectation by citizens that they will also play a significant role in actually helping to improve health, or at least maintain health in a good state. And I think that may well be because of what people saw as part of the response to the COVID epidemic, sadly still ongoing. The COVID epidemic in the UK still is the largest, the most important, and the most destructive in the UK for many decades. But epidemics, very frightening epidemics, occur actually quite regularly around the world. And I've just illustrated this with a few epidemics within my professional lifetime. Ebola, where it's still, there are epidemics, there's a small epidemic, but it could easily grow at any point in the Democratic Republic of Congo. But there was a major one in West Africa, as people will all recall. AIDS, probably the last massive pandemic with enormous impact on health around the world. Zika, a more recent one. SARS, a precursor in many ways to COVID. The swine flu pandemic, a major pandemic, but with a disease that fortunately had a very low mortality. And then smaller epidemics occur every year in every country, or outbreaks of things like norovirus and other vomiting, other diseases. So these are actually quite common, and in all of these, local citizens would expect the state to act. The state has also long been seen as responsible for protecting from contagious endemic diseases. These are diseases which are there the whole time. There are some extreme examples from this. For example, leprosy was a disease which, if people had it and they were diagnosed, they would be completely excluded in a very formal process from society, and then society would often maintain them, the government in many cases would maintain them in groups, leper colonies as they were called, and I've illustrated this with the Hospital of St Giles, which is administered by the City of London, where I currently am speaking from, until 1299. So here's an early example of local authorities intervening to take an individual out of society as it was then perceived to protect the general population. In fact, a misunderstanding to a large extent of how leprosy was transmitted. And tuberculosis wards, fever hospitals, these have been a responsibility of government of different forms in many societies for many, many years. So the idea that the state should help to protect against infections has been long-standing. And in fact, the reduced threat from most contagious diseases has allowed a more muted response recently than used to be the case, because it is important for all forms of state intervention to help protect health that it is proportionate. If this is illustrated here by Lowry's famous painting, very sad painting, The Fever Van. In the 1930s, when he was painting this, the state, in the form of local authorities and medical practitioners, if a child had major contagious diseases, for example, scarlet fever, the child would come and be removed from their home, all their possessions would be burned, they'd be taken off to a fever hospital where their parents could only see them through the windows. Often they would then die. This was quite normal state interventions. Because of improvements in sanitation, housing, diet, vaccination, and above all antibiotics, we are now in a situation where this kind of intervention would, outside major epidemics, be incredibly rare that the state would intervene in this kind of way, but it was commonplace. So in fact, in many areas like this, the state now intervenes substantially less than it did historically. Then another area where the state is very heavily involved is voluntary mass vaccination programs. I do want to stress the word voluntary. People sometimes forget what it was like in a pre-vaccine world, and I've illustrated this with a ward full of people who had caught polio, a vaccine-preventable disease, were paralysed and had to live their lives in these iron lungs, which were what kept them alive. This is another example where reducing my neighbour's risk, reducing my neighbour's children's risk, helps reduce my risk, helps reduce my children's risk. So this is a situation where voluntary vaccination programs, mass vaccination, helps protect everybody in society. And generally, for these kind of programs, the higher the coverage, the greater the protection for everybody, including those who have not yet been vaccinated. Another area, again linked to infection, is providing clean water, sewerage, and regulating waste to reduce infection. And this has been seen as the responsibility of government, often local government, for centuries and in some cases millennia. Illustrating this with the Pont du Gard in Nîmes, built during the Roman era. But for London, probably the most important development of this, and one of the great things of the 19th century, was the provision of clean water and, above all, sewerage in London. This is what allowed the growth of London and stopped many of the huge epidemics and the major endemic diseases, such as typhoid, cholera, and diarrheal diseases. And I've illustrated this with Joseph Bazalgette, who was responsible for much of this, and one of the great sewers of London that he helped to have constructed. So water and sewage is a relatively uncontroversial area that is highly supported by people under almost all circumstances. The principle that the state should regulate food to keep it safe is long-standing. It's been expected of the state for a long time, but it can be controversial in practice. And here we move into the first area of potential controversy. Now, this is, as I say, it's gone back a long time. Medieval cities had regulations about preventing spoiled food being sold, and cleanliness and a variety of other things to help try and reduce the risk of infection. Sometimes they actually allowed the food to be sold to strangers, but prevented it from being sold to citizens. And I'm going to just give 3 examples which the state had to act for public health with food, but which were controversial about whether the state should act and how it should do so. The first of those is the compulsory pasteurization of milk. And this was primarily to protect children, especially from TB, tuberculosis, but also brucellosis, staphylococcus, and various other things. Unpasteurized milk is a perfect growth medium for large numbers of quite dangerous pathogens. And this was brought in as a compulsory thing in stages between the 1920s and the 1950s. This was a very serious issue. Taking TB alone, at the point this started, about 1,600 children were estimated to die from TB caught from milk, and many others would suffer significant disease and disability from that, or diseases like brucellosis. So this was not trivial. But there was a very strong lobby against it. When people tried to bring this in through Parliament, made up of parts of the dairy industry, actually particularly the higher-end parts of the dairy industry, who felt that their superior products were going to now compete on a level playing field with other ones, and people who were philosophically opposed to interference for a variety of reasons, ranging from they wanted natural products to those who believed that actually the best way for children to get in immunity was to be naturally infected. Of course, then leading to many thousands of deaths over the decades, which were in fact preventable by heating milk for a relatively short period of time. But there was quite a strong lobby against. This is now broadly very uncontroversial, but it was controversial at the time. Another example where there was a lot of controversy was in the 1980s, salmonella in eggs here in the UK, now gone very largely. This shows again how tricky it could be. It was a major public health issue. There was no doubt about the fact that there was a lot of salmonella, not in every egg, but in much of the national flock. And the true statement by a minister at the time that most of the egg production in this country in 1988 sadly is now affected with salmonella led to a massive reduction in egg production, mass slaughter of chickens, and the minister having to resign, a minister called Edwina Currie. Initially, this was managed by compulsory slaughtering of chickens, but then science came in and produced a vaccine, and poultry vaccination has contributed to a complete recovery of the UK poultry industry. And lion mark eggs are one of the ways in which we can see that has happened, completely superseding mass slaughter of infected flocks. And over time, this has led to a real change in the number of people getting salmonella. So in the early 90s, over 18,000 cases. By the 2010s, less than 500. So a real turnaround as a result of this intervention, but controversial at the time. And finally, the BSE and new variant CJD are very tragic and debilitating, but fortunately rare neurological disease caught from infected cows. Really most affected the UK, not exclusively. And what you had is a significant peak in epidemic of BSE in cows, and then a smaller but still important ongoing peak of infections of humans who had this terrible neurological disease. It led to a major mass slaughter of cows, substantial change in the industry, and had very big economic impacts. Again, highly controversial. At the time it was there, but a strong expectation by citizens that the state would act to maintain the safety of food. So those are all areas around infection. The second area, and these are much broadly more discrete areas, is that there is broad support for the role of the state in reducing air pollution across the political spectrum. And I've just shown some front pages from newspapers which are not always politically in exactly the same place. And again, this makes complete logical sense, because it is impossible, really, to reduce the risk of outside air pollution for me and my family without also reducing it for you and your family. This is an area where individual action will not work. So you have to actually operate at a societal level, and the state can allow that to happen. Again, this has been considered a responsibility of government for a very long time in a variety of different ways. For example, here in England, King Edward I banned the use of sea coal, a particularly polluting form of coal, in London in 1272. And there have been multiple examples of that since then, some of them indeed associated with people who worked in Gresham College. The biggest spur to UK action on air pollution was the Great Smog of 1952. And this is when a combination of cold and atmospheric conditions in a period when coal was used as the principal heating and also power generating source led to at least 4,000 people dying over 3 days of severe smog, and it may have been as much as 12,000, so a really quite astonishing impact. This led, after quite a bit of parliamentary controversy, but it led to the Clean Air Act of 1956 and several things that have happened since then. And this will have led to substantial reductions in cardiovascular and lung disease, because air pollution has significant effects on heart and heart disease and stroke, as well as on the lung. Now, the big heavy industries that use coal as their principal aim have been largely cleaned up or have moved over to cleaner sources of fuel. And this shows sulfur dioxide, one of the major pollutants, over time, and where the concentration of this still is. And you can see a remarkable reduction from the 1970s on the left through to around now, where it has almost entirely disappeared as a major pollutant, except around very specific sites. And the UK is actually doing fairly well in tackling emissions due to many of the main air pollutants. The exception, the one that is still very difficult, is motor vehicles of different sorts. And that's because you have to have the polluting thing, the vehicle, and people in the same place. You can't move it away from people because this is actually the way that people get around and need to get around using vehicles. And this form of pollution is therefore going to be one of the hardest ones, and but there are going to be significant improvements, spurred on, as I'll show you, by state action. Now, the most extreme example of how to deal with this was in the issue of lead in petrol, an instructive example, if a rather extreme one. Lead has been known to be toxic for 2 millennia. And General Motors started to add lead to petrol from the 1920s. And they did this to deal with a problem to do with compression, something called knocking. It's an engineering solution, but there were other engineering solutions available, but this one could be patented and those ones couldn't. So that was a lot of the thing which actually drove this. Very strong warnings, particularly from this remarkable woman, Alice Hamilton, who was one of the forerunners of preventive medicine, from the off. But 3 decades of research dominated by the industry at that stage all claimed that lead in the atmosphere probably didn't do anything, and if it did, it was there naturally. By the 1960s, the data, the science demonstrated that lead in petrol actually had really dangerous effects, in particular on the brains of fetuses and children. Significant reductions in IQ, may even be some links to crime for reasons that were not fully understood. And restrictions began to be introduced by the state to help the motor industry wean itself off lead in petrol that was causing real damage to children's development. And although it had been predicted by people who were trying to support the use of lead that actually almost all the lead in the atmosphere had nothing to do with petrol, when it was removed, as you can see here in the UK, the amount of lead in the atmosphere essentially completely disappeared. The final ban on UK petrol, which had lead in it, was 1998, but it was being phased down significantly before then. And this is an example of the state doing something slightly different, which is providing regulation to give a level playing field to industry in an area where everybody is potentially affected, and saying, let's spur on innovation, engineering innovation, to engineer out the in this case, pollution, but it could be other risks. And if you look at this gradually tightening regulation that's happened here in Europe and elsewhere in the world as well, I'm just using the Europe one, what you can see is that both for petrol and for diesel, over time, the amount of particularly nitrogen oxides, and particulate matter, which are 2 of the major pollutants that come out of vehicles, have gone down in stepwise way as the regulations have become tighter and engineering has responded, and then the regulations tighten again, engineering responds, and these pollutants are gradually decreased. So this is an example of the state using regulation with industry to make sure, provided people no one cheats, and that there is obviously some rather depressing examples of that, but provided people don't cheat, to keep the vehicles running, which people want, but reduce the risk to overall health. And finally, before I move off vehicles, I think it's just worth looking at road traffic accidents, to consider how the state can intervene in multiple ways, most of which are really uncontroversial, to help protect the health and lives of citizens. And I've grouped these into 4 different groups, the first of which is by regulation. Rather like with the things that were being done to spur innovation to reduce pollutants in the atmosphere, car design regulations have steadily made cars safer and safer, including things like crumple zones, airbags, compulsory engineering in of seat belts, and so on. The second area where the state can act and has to act is areas where it provides the infrastructure. So road design to make it safer, road lighting, maintenance to ensure that there aren't big potholes that lead to significant car accidents. Then there's a group of things which are about providing laws for all of us. They do protect me, the driver, my family, but they also protect me from other people. And that's the reason why the state has to act in this way. Speed limits. Me driving along at a steady pace doesn't help if the person coming the other way is driving far too fast for safety in the road conditions. Driving tests to ensure that people have a minimum level of competence before they're let out on their own. Again, it's what happens if someone crashes into me you should worry about. Drink driving laws and drug driving laws, which ensure that someone driving towards you is actually capable of a straight line because they are unlikely, if they are within the law, to be drunk at the wheel, which is steadily tightened over time. And the MOT test to make sure that the car coming towards you, overtaking rather fast, actually has good enough brakes to be able to stop. So these kind of things are areas which protect, although they're a nuisance for all of us individually, they help protect us from other people and therefore provide a safer environment. The one that was the most controversial was the introduction of compulsory seatbelt wearing, first in the front of the car in 1983 and subsequently in the back of the car. And here there was a battle between those who said this is going to reduce road deaths and those who said it's the unalienable right of a British man or woman to drive without a seatbelt. A lot of rather hocus-pocus science was quoted in this, but that was the fundamental clash of ideas. But those who argued that this was a significant contribution to improving road safety won the day in Parliament. That was the view, after some debate, of the population as expressed through Parliament. And I think nobody would now go back to a situation where people were just driving without safety belts. I think the evidence of safety belts is not uncontested, but is pretty strong in most people's views, that they significantly reduce the risk to people in the front and also people in the back. The combination of all of these has led to a very substantial reduction in deaths from road traffic accidents from cars. So what we have, road accident deaths in the late 70s, over 6,000 a year. Now, in this period, 2019, the last for which we have full data, 1,748. That's a very substantial reduction. And this is through incremental activities, much of which was spurred on by state regulation or state decisions. The next group of things where the UK public, as expressed through Parliament, believes the government should reduce the risk is for someone who goes to work preventably being killed solely because they've gone to work. If you look back, within living memory, thousands of people were killed at work. And even if you just go back to the 1970s, it was the high hundreds of people were killed in industrial accidents. We're now down to a situation where, fortunately, only, each one of these a tragedy, but only 92 people were killed due to work-related activities in that year, a remarkable reduction. And the UK is actually, from a work point of view, one of the safest places in Europe and indeed the world. Now, people grumble often about health and safety regulations, but very many of these are to make sure that the fact that someone has to go to work for their employer is not the reason why they either don't go home that night or they go home and subsequently have a disease or injury which will have lifelong implications for themselves and their family. There is also generally support, as expressed, again, through democratic processes, for action against occupational causes of disease, in particular cancer. Some cancers are largely caused by a particular occupation. And these have varied through history, depending on, as industries have risen and fallen, those have changed. So one of the earliest recognized examples, for example, was a rather unpleasant cancer called Pott's scrotal cancer of chimney sweeps. And this has gone away because there are no chimney sweeps who are not in a regulated industry. It's now not seen, but was relatively common in people who were doing it. Much lower rates now. Around 4% of UK cancers are currently attributable to occupation, and probably only about 1% avoidable in practice. And the most important of these was exposure to asbestos, which probably kills around 4,000 people a year. Almost all of these people would otherwise not have died of what they die of, which is a form of lung cancer. The variety of forms of lung cancer can cause, but particularly something called mesothelioma. And again, this was something which was introduced by industry, a brilliant product from a purely engineering point of view, asbestos, but it led to those who were heavily exposed, particularly workers, and their families, if they were, for example, exposed to the dust, having significant exposure, and mesothelioma is an extremely unpleasant and deadly cancer. And what you can see is it has some bands of the most dangerous sort in the 1980s and of the still dangerous but slightly less dangerous sort in the 1990s. We should have acted much faster. And depressingly, if we'd acted at the earliest point we knew that mesothelioma was caused by asbestos, it would have been much less widely used, and many people who died of this really unpleasant cancer would not have done so. The peak of mesothelioma deaths is around about now because there's a delay, and it will continue to fall now for the rest of the lives of everybody who's watching this programme. Getting into slightly more difficult territory is where a wealthy industry causes harm and depends for addiction on its operating model, or where it harms other people who haven't bought the product. And the archetypal one of this that ticks all of these boxes is the cigarette industry. I think everybody will know that lung cancer is the commonest cause of cancer deaths in the UK. Most people diagnosed today and this week will be dead within a year, and it's an extraordinarily unpleasant cancer for very many people. The great majority of those deaths are because an exceptionally wealthy industry has used incredibly effective marketing techniques to push highly addictive products they know will kill their customers, they know it will kill their customers, onto them at a very early age and historically in childhood. Smoking also causes heart disease, stroke, lung diseases, other cancers. And importantly, additionally, if someone else is smoking in the room, their smoke can damage my health, can kill me. So it has multiple reasons why society might be concerned about this. And just to back up this statement, the lung cancers are the most important in terms of mortality. Significantly more important than prostate cancer, the commonest cause in other cause in men, and breast cancer, the commonest cause in women. Smoking is at the heart of the great majority of that. Again, just to back up my point, targeting of children and teenagers, something which society rightly deplores in any form, whether it's industry or anybody else. Here are just a few quotations from the days before this had really become a big issue. School days are here, and that means big tobacco business. Let's get it. That's from the 20s. But still, by the 1970s, the base of our business is the high school student. And there's a consistent pattern through history of the cigarette industry claiming to deplore child and teenage smoking whilst undermining all efforts to try and control it. And interestingly, 74% of smokers, according to YouGov, think smoking should be banned in cars with children. So a very strong belief by the general public that we should protect children, and we should also protect people from other people's second-hand smoke, because they're not choosing. An individual can choose their own risk, but they shouldn't be choosing it for their neighbour, and they shouldn't be choosing it for children. Most data would suggest that the great majority of smokers want to quit and try, but they have been addicted to something with really strong marketing. So it is very important that we never blame individual smokers for lung cancer. They are up against one of the most powerful and wealthy industries in the world. So does the state have a role in this situation? Well, I think one thing, just to get a feel for the level of disparity, and remembering that smoking is particularly now targeted on people from lower income levels and often more deprived backgrounds, is just to think a little bit about the extraordinary profits that this industry brings in. I'm not going to read all of these out. They're all openly available documents. This happens to be from British American Tobacco annual report. But I think I'll just highlight two things about this. The UK High Court accepts that the net economic effects of tobacco use to society are around £13.7 billion a year, and the industry pays around 10 billion in taxes, plus causing significant long-term health problems for individuals and their families. The profit for just this one company is 3 times the total amount invested in health research by the Medical Research Council, National Institute for Health Research, and the Wellcome Trust, the big funders of health research in the UK for all diseases. So this just gives you some feeling for the size and strength of this industry, and this is the reason why an expectation is there by many people that if they're targeting children, if there's second-hand smoke, if people are exposed at work, the state should intervene. Then there are a variety of situations where the state provides services on a voluntary basis, but on a mass scale. And I'll just highlight 2 of those. The first of those is screening, which I'll do a full lecture on. Cervical screening in women has led to a substantial reduction in cancer. Around a 40% reduction, I think, would be a fairly standard estimate of this. And bowel cancer screening, breast cancer screening, and other successful programs have also led to substantial reductions in mortality from these important cancers. And it does this primarily by the state providing a service which detects the infection in the case of cervical cancer, the cancer in the case of the other cancers early, so they can be treated quickly and minimally, dealing with the problem at the earliest possible stage. So, and then the other one, as I talked about earlier, was mass vaccination. So these are the areas where the public expects the state to act, as revealed by what has been done over usually centuries, or certainly decades, and has gone through Parliament and other democratic processes. Where risk is shared across society, your risk is my risk, epidemics, infectious diseases, pollution, where there's a major power imbalance which may kill people, and where it's about protecting the most vulnerable. And this has led, in part, many other things have contributed, as I say, including improved quality of living, diet, massive improvements in medical science for treatment, to an extraordinary impact in disease over time. But then there are some areas which are much more contested, and I'm just going to raise them. And these are the areas where different times in history and different states and different political persuasions will come to significantly different answers as to what is the role of the state in preventing disease. And the first of these is the role of the state in paying for and providing individual medical treatment, including secondary prevention. And this varies very widely by tradition and politics. In the UK, at this time in history, there is a very strong and almost universally, not completely universally, supported position that we have provision by the state free at the point of delivery. And within that system, GPs, general practitioners, do the great majority of secondary prevention. Some hospital doctors, NHS doctors do as well. But other nations, equally advanced, equally scientifically literate, equally civilized and humane, have widely differing approaches to state responsibility for treatment. And if I can just show this scatter graph, this comes from the Global Burden of Disease study. What it shows is the proportion on the left of health spending from the government, and on the right, the gross domestic product of the nation involved. And within that, there is a broad trend that wealthier societies pay for a higher proportion of treatment. but is by no means universal. And many rich countries will, for example, pay much smaller proportions of the cost of treatment. This is very much, therefore, a contested area of whether the state should act or not, depending on political tradition. But in the UK, a very settled view about whether this form of prevention, done through the curative services, GPs in particular, should be provided by the state. And then finally, what should the state do about harmful health trends which depend on an adult making individual decisions? And this becomes a bit clearer, I think, when we're talking about children. But particularly when we're talking about adults, this is a contested area. An example here is rising obesity, which is a major threat to health. It's often driven by heavy and persistent marketing by perfectly respectable firms, or by limited choices. And the limited choices, I think, is highlighted by the fact these are year 6 children in terms of their level of obesity, and this is by deprivation level. And the most deprived, on the far left, have significantly higher rates of obesity in childhood, in year 6, than the least deprived. So a strong link there. And the state pays for the consequences. Obesity will lead to many diseases, which will lead in long term to other areas. What is the role of the state in combating this? That is something which different people from different persuasions will come to different decisions about the relative importance of the state role. But broadly, the bottom end of this is relatively uncontroversial. Supporting science to test possibilities to improve the situation, informing the public, providing information so they can make better choices. Many foods, for example, people don't realize what's in them. Engagement with industry on a voluntary basis, because most industries want to do the right thing, and if you provide a level playing field, they will do so. But there becomes more controversy about whether we should go further into nudge taxes, regulations, and in particular, heavy taxation, banning or making individuals subject to criminal or civil law. And I think most political traditions would, in the UK at this point in history, would move very, very cautiously about going further than halfway up this ladder of interventions unless the evidence is really clear that's the right thing to do. So here's an example where the state, in the form of the government, duly elected government, went halfway up that ladder. And this was the soft drinks sugar levy. And this took soft drinks, sodas in other traditions, and it said no tax below 5 grams of sugar, and then there was a kind of a ramping up of tax depending on how much sugar there was. The result of that was industry reformulated down to the levels. So they didn't stop the products, they simply reformulated to reduce the amount of sugar. And the response to the result of this was total sales went up 14.9%. And they went up, these are the blue bars, in every social group. So individuals continued to buy their favorite drinks. The supermarket, the drinks manufacturer continued to get their profit. But the total amount of sugar went down by a very substantial 35% overall, and this was true in every social group again. So here's an example where a nudge tax, in relative terms, led to a reformulation by industry, and that led to no long-term impact on people's choices or industry's profits, but a significant reduction in a particular health risk. So this is going a little bit over the way up the ladder of intervention. But how far people will go does depend on evidence. And the more contested something is, the more absolutely critical the evidence is robust. And 3 things have to be kept broadly in balance. The difficulty of the intervention, which includes how unpopular it is. So banning sweets would be extremely unpopular. You'd have to have an extraordinarily good reason to do that. But you might want to do some other milder interventions. Cost, how long it's going to take, a whole variety of other things. The second thing that has to be kept in balance is the size of the health effect. If the size of the health effect is going to be really substantial, people will be tempted to go further up the ladder than if the size of the effect is going to be, at the end of the day, pretty trivial. And then the final question, is the strength of the evidence. If you've got very weak evidence, even if you're claiming it's going to have a big effect, then do not expect people who are elected politicians to go much of the way up the ladder because they will feel that's an inappropriate thing to do in this more contested area. So this triangle of difficulty of intervention, size of the health effect, and strength of the evidence, I think is something that people who provide health advice and provide look at science for public health need properly to keep in balance. And I've illustrated this just because it's happened recently by the Penrose triangle, after Sir Roger Penrose, who was in fact Gresham Professor of Geometry here, and has just this year won the Nobel Prize. Finally, before I summarise, for those who are sceptical of the state's right to intervene for wider public health in these more contested areas, so I don't think this is true for the areas like epidemics, infections, air pollution, but in these more contested areas, certain things will make it more likely that citizens and therefore politicians elected will be comfortable. If it's protecting the vulnerable, children, the elderly, others, if there's strong evidence, if there's a big effect, if it's obviously cost-effective, and if it has a particular impact on the healthy working-age population because that feeds through to wider societal benefits. They will be more sceptical if it removes existing rights, removes pleasures, exposes citizens to laws that weren't there before, provides a barrier to trade, expands government, or a constant fear has unintended consequences. And I think people who think about these interventions in the more contested areas, I think have to think about all of these potential issues. So my final point. There has been a remarkable improvement in health over the last 150 years after a long period of relative stasis since when this college was founded, so from about the 1850s. Much of that has come through better housing, better diet, and things which go with growing economies. Much of it has come from individual decisions, and much of it has come from medical science leading to massively better diagnosis and treatment. But a lot of it also has come from the state acting to prevent disease, particularly in people who currently are well, but if the state did not intervene, might well be injured or have diseases of a variety of sorts. And the period of history of formal state medicine in the UK, certainly for central government, can I think reasonably be started with the first Chief Medical Officer, Sir John Simon, who was actually first appointed in 1855, just to the point that this graph went up. This isn't cause and effect, but throughout this period of extraordinary improvement in first child and then adult health, state medicine has played a very major role, and one where most citizens, through their elected representatives, have been highly supportive. Thank you very much.